I have a long introduction, but I'm told by Dr. Goldenberg that I'm not allowed to do a long introduction. So I'm not really okay with that, but I will cut out a couple of paragraphs. First, I can say thank you so much for coming today again. We're grateful to have Dr. Goldenberg here on the Florence Cobb visiting professorship. So that is the situation under which he comes here to us from Columbia University Medical Center in New York. I have a large paragraph about how successful he is domestically with NIH funding. He's been funded by all sorts of institutes. He's been on all sorts of advisory boards. Let it be known he's very successful domestically, but obviously he's here in the context of global health today. So let it be known that he is also incredibly successful in global health. He's been working in the field for 30 years. I will read the last two paragraphs, which I think are very important to me, which are that Dr. Goldenberg, you can see, is very committed to women and children of the world. But in addition to that, he's committed to people like me and you. Dr. Goldenberg has and continues to be my primary global health mentor and has been the most influential character in my story, let alone the lives of many mentees that have come before and after me. I'm very pleased we have this opportunity to learn about health outcomes in low and middle income countries and feel there's absolutely no better person to hear this information from than Dr. Goldenberg, who's undoubtedly improved those outcomes through his career commitment to large multi-center studies serving the most needy populations on the earth. So thank you for the opportunity to introduce my mentor and role model, Dr. Goldenberg. Without further ado.
Okay, can everybody hear me okay, I assume? All right, so one of the really nice things in my life was having the ability to work with Margot. I don't know how many years it is, but it's probably around 10 by now, right? Close to 10. Margot has probably published 20 papers with me or something like that. Has been one of the really successful people that I've worked with over the years. And it's been a real pleasure. It's a real pleasure coming here and getting to work with her again. Okay, so what I'm going to do is talk about pregnancy outcomes in high and low income countries. I'm going to focus on low income countries, but what you'll see is what I try to do is learn what's happened in like the US and other high income countries in terms of several outcomes to try to give me a sense of what might be useful in lower income countries. So I'm going to go back and forth a little bit between high and low income countries. So I'm going to talk about, there are a lot of outcomes one can look at, but I'm going to talk about maternal mortality, stillbirth, and neonatal mortality. Maternal mortality is the death of a woman during pregnancy or up to 6 weeks. Stillbirth is born dead. There are many definitions that I'll talk about. And neonatal mortality is a baby that's born alive, dies by 28 days of age. And I'm going to try to explore reasons for the poor outcomes in low-income countries and maybe give some possible solutions. So much of the data that I'm going to talk about comes from the global network, and I want to take just a couple minutes to describe that network. It's funded predominantly through National Institute of Child Health and Human Development. It partners U.S. Universities, people at U.S. universities, with people at universities overseas. It was funded about 20 years ago, initially by NICHD and the Gates Foundation. And the goal of the global network is to perform collaborative research focusing on the leading causes of mortality and morbidity in pregnancy and early childhood. And another goal, which is really important, is to help develop sustainable research infrastructure in low-income countries. And so we try to do the both together. The current sites, and we have to compete every 5 years for the global network. The overseas sites are Guatemala, the DRC, Zambia, Kenya, Pakistan, which is where my primary relationship is. There are 2 sites in India and a new site in Bangladesh. And you can see the universities that they collaborate with. And again, from Colorado, has had a long-standing relationship with the group in Guatemala. So, but each one of these relationships is really sort of unique. Many of them are really neat to try to understand how they've happened. I've spent a fair amount of time in one of the Indian sites and tried to in fact, we've written a few papers on how that collaboration between the U.S. university and the site overseas in India has really built a whole research infrastructure in that part of India. One of the things that the Global Network done is it started now about 10 years or 11 years ago, is to build a maternal newborn health registry. And most low and middle income countries, not all, but most don't collect reliable pregnancy-related data. And it's very hard to know really what goes on in terms of the outcomes in those countries. And in fact, more than the outcomes, what are the processes, what's happening in relationship to pregnancy and newborn health. So every site in the Global Network that I talked about has between 10 and 20 geographically distinct communities with about 500 births per year in which pregnancy-related data have been collected since about 2008. And since 2008, we have a database now that has more than 700,000 pregnancies in it, pregnancy outcomes. To the best of my knowledge, that's really probably the best general pregnancy outcome database in low-income countries anywhere in the world. And I think, Margaret, you have 6, 8, 10 papers using that database. So over the 19-year history of the Global Network has published, I said more than 200, I think it's about 300 papers out of that database and the studies that it's done. It's done 19 multi-country randomized controlled trials, and the topics addressed are wide-ranging from postpartum hemorrhage to childhood malnutrition, newborn resuscitation, ultrasound, antenatal corticosteroids, aspirin used to reduce preterm birth, emergency medical obstetric care, and many others. And the group in Colorado has taken the lead on nutrition studies during pregnancy and childhood. So now I'm going to switch and just talk about 3 outcomes. I'm going to first on maternal mortality, then on stillbirth, and then on neonatal death. So throughout the world, there are something like 300,000 maternal deaths annually. And we don't exactly know how many because the data is lousy. We don't even really know how many occur in the United States because our data is lousy. But the people that I work with, especially at the Gates Foundation, thinks about maternal deaths as sort of the tip of the iceberg, that it's a sign that bad things are happening to women. But in fact, many other bad things happen related to pregnancy outcome. And what they point out is that even though there are 300,000 maternal deaths, there are more than 10 million more women are affected by something bad that happens during their pregnancy, such as obstetric fistulas and other things. And where on earth the birth occurs is the primary factor that predicts its outcome. So this is, I'm going to show you a bunch of slides that sort of look like this. So it's a world map, and the colors indicate the degree of bad outcomes. And the darker in this slide, and probably the others too, the darker the color, the worse or the more common is the bad outcome. So this looks at maternal mortality, and I'll show you some of the actual numbers. But the best countries in terms of maternal mortality, the lowest rates are Canada, Western Europe, Australia, Japan. And the worst countries are Sub-Saharan Africa and Pakistan and India generally have the worst outcomes. And I'll show you some of the numbers here. So if you look at maternal mortality by country, and maternal mortality is given per 100,000 live births. The other numbers are per 1,000 live births. Sweden, the Scandinavian countries, Japan, all have maternal mortality rates about 4 per 100,000. The country in the world where we think is the worst outcomes are South Sudan, which that number is about 2,500 per 100,000. So if I got the math right, what that means is that 2 to 3 women out of 100 die as a relationship of their pregnancy. The United States, while compared to South Sudan and many of the other countries, does pretty well compared to Sweden and Japan, and does poorly. And I'll talk about that in a little while. But you can see the other countries, the approximate rates. And again, we don't know these numbers very well, but generally run between about 100 per 100,000 and about 500 per 100,000. So if you look where the maternal deaths occur, the blue or the dark blue or purple shows the deaths in developed countries. The lighter blue or teal is in Latin America. So there are a few deaths there, but the vast majority of maternal deaths occur in Asia and in Africa. And so that's where the really big problems occur. If you ask the question, why do women die? Most of the studies show pretty much the same thing. The major cause, or the most common cause, is maternal hemorrhage, infection, and eclampsia. I'm going to talk a lot about eclampsia, especially. But those are most of the studies show about a third, and a third between eclampsia, infection, and hemorrhage. Now, going back historically, if you look at maternal mortality per 100,000 live births, if you go back before about 1930 in the United States, the maternal mortality rate was in the range of 800 per 100,000. So I like to wander through old cemeteries, and there's an awful lot of young women, women in their late teens or 20s in those cemeteries. And most of those relate to this maternal mortality that I'm talking about. But then beginning in almost exactly 1935, the maternal mortality rate in the US started precipitously dropping. And so one of the questions that we have asked in many different ways is, why did the maternal mortality start dropping in 1935? It was mostly finished by 1970. And what happened? And will that provide a clue to what one could possibly do in low-income countries? And this slide looks at, we had some numbers from the United States, which is the top line, UK, which is the middle line, and Sweden, which is the lower line. And even though there were fairly large differences in maternal mortality among those three developed countries, the rates all started falling in about 1935. And you got to the lowest, a pretty low rate by about 1970. We've gone back and tried to understand why was the rate in the United States so much higher than these other countries. And I've got an opinion that's not widely shared, but it has to do with the awful medical care in the US. And if you go to Sweden, all the maternity care was almost always provided by midwives who didn't screw around. They took care of women. They didn't use anesthesia. They didn't use forceps. They just took care of the woman and delivered. That was more common in Great Britain. But in the US, what you had was all kinds of experiments with different kinds of anesthesia that was not well monitored. Even when I started my residency in OB, people were using high forceps. They were, very dangerous. They were doing things called version extractions. They were reaching into the uterus, grabbing, a vertex baby that would have probably delivered fine, grabbing the legs and pulling it out. They were doing all kinds of stuff like that. And my guess is that a fair amount of that is iatrogenic. I can't prove that, but that's at least what I think. And it looks like if you just don't mess around, you can probably get your maternal mortality down to not to 4 or 10, but to 100 to 200. That's sort of an editorial. The country that has the best data is Sweden, and Sweden has been collecting relatively good statistics since about 1750. And so this just looks at the maternal mortality in Sweden, which was pretty steady, and sort of almost 1% of all pregnant women died. That's 1,000 per 100,000. And then also, beginning about 1935, the rate just started falling. And so what happened, a number of people have looked at this, but started talking about increasing antenatal care. And I'll talk about what that meant. But sulfonamides became available in the late 30s, penicillin in 1940-something, and blood transfusion also during World War II. So 40, I don't remember the year, but 42, 43. And the people from Sweden that write think it's that combination of stuff that led to the reduction in maternal mortality. They actually had some data by cause, and this is, for me, incredible data, also from Sweden, and looks at 5-year intervals in this particular slide from 1931 through 1950, and looks at the causes of maternal mortality. And the first thing to note is that the maternal mortality, like I've been showing, fell dramatically from 1930 to about 1950. The red and the yellow are infection-related causes of death, and those virtually disappeared between 1930 and 1950, and that most likely has to do with antibiotics. I'm sure a little better care probably helped, but I think that was mostly antibiotics. But the eclampsia business, which is in the purple, and the other stuff didn't change very much. So mostly the early reduction in mortality had to do with better care for women with infections. Now, and then this slide looks from 1950 to about 1980, and I messed up the colors. So they're not the same colors as on the previous slide. But in the 1950s, the major killer of pregnant women was eclampsia. And, I started my medical school somewhere in the mid-60s. And eclampsia was really the thing that the obstetricians worked on and worried about. And you can see that between 1950 and 1980, the deaths from eclampsia almost disappeared. And I'll try to show you why, because I think it has some real implications for women in lower income countries. But now, if you look to the far right, if you look at 1976 to 1980s, the biggest killers of pregnant women are things like embolus, heart failure, more medical kinds of stuff. They're not so much public health related issues. So we went back and we looked at from lots and lots of different publications the eclampsia prevalence and then the case fatality rates over time. And what this slide shows is that number one, the prevalence of eclampsia dropped dramatically. So eclampsia, for those that don't pay attention, is a seizure associated with preeclampsia or with high blood pressure during pregnancy. And the prevalence of those seizures disappeared. I'll show you that the prevalence of preeclampsia didn't change any. So what that meant is that we had better medical care for the women with preeclampsia. We delivered them earlier. Basically, that's the treatment. And so the prevalence dropped dramatically. And then among the women that did have seizures, the case fatality rate also dropped almost to zero. So there was far less eclampsia, and among the women that got eclampsia or that had an eclamptic seizure, the mortality dropped almost to zero. And so what you had is this huge reduction in eclampsia-related mortality. And we've tried to understand So if you go back 100 years ago in the U.S., eclampsia was very common. Perhaps 1% of all pregnancies, all pregnant women ended up with eclampsia. And of those, 20 to 40% died. And now eclampsia is probably about 1 in 5,000, more or less. And maternal death just doesn't happen anymore. So what happened in the U.S.? Basically, it was increasing access to prenatal care. And what prenatal care did is it took blood pressures, it looked for protein in the urine, referred women with this condition to a hospital where they got delivered. And if you do that, mortality drops dramatically. For a while, it used to, pregnant women with preeclampsia, eclampsia used to be kept in dark rooms and be given sedation and that sort of stuff. And in fact, the women still died and their babies still died. It became very clear that when a woman was pretty sick with preeclampsia or had an eclamptic seizure, what you needed to do was deliver the baby. And the advent of newborn intensive care, in fact, made delivering those premature babies much easier because they had a much better chance of surviving. So it was a combination of better neonatal care plus the obstetric care. And again, I point out that there was little or no change in the rate of preeclampsia. So it wasn't that the underlying disease was reduced. It was just the treatment was better. And this is an issue that I've dealt with a lot, but the magnesium sulfate is a drug that reduces seizures. And there's a mythology, which I'll call, that magnesium is responsible for a lot of this reduction and is important. The Gates Foundation is funding all kinds of stuff to introduce magnesium sulfate into low-income countries, which I think is a huge mistake. Not that it doesn't provide a little benefit, but that almost all the change historically occurred before magnesium was even used. And it was hardly ever used in Great Britain, and they had exactly the same reductions in mortality that we did. And so most people don't listen to me on this issue because they want a silver bullet to fix this. But the silver bullet is not magnesium. The silver bullet is screening women for preeclampsia and delivering them early. Anyway, that's the lecture. Magnesium sulfate may reduce maternal mortality somewhat, but should not be the cornerstone of maternal mortality reduction programs. And there have been a number of those funded that have failed to reduce mortality. So preventing maternal mortality is really not hard. There's infection. Use more sterile techniques. You can give antibiotics. If there's hemorrhage, you can do blood transfusions. Obstructed labor, you can diagnose it and do a C-section, abortion complications, and so forth. We've known how to do this stuff for years and years. But the issue is trying to get it implemented in a way in low-income countries that are consistent. Anyway, I just wanted to put in this one slide, the maternal mortality increase in the U.S. So if you go back 20 years ago or something like that, it was believed that the maternal mortality rate in the U.S. was 7 per 100,000. Whether that was right or not, because our data is sort of lousy, is not clear, but it was low, similar to what it was in Sweden and Japan and countries like that. But lately, the number was 28 per 100,000, and then it's 21 per 100,000 now. And the reason for that, at least to me, is not clear. Whether it's better reporting, that we're doing better case finding of the maternal deaths, but it may also be who's getting pregnant. So the women are heavier, they tend to be older. While I was still practicing, we were taking care of women with renal impairments, major diabetes, And so it may be that these women are just at increased risk. And we're also doing a lot more C-sections, and that has a mortality risk of its own. So I don't know the answer to that. For me, it would be a wonderful study for somebody to undertake, but I haven't seen a really careful analysis of that. Okay, I'm going to switch and talk about stillbirth. And this has been an interest of mine for a long time. We don't know how many stillbirths occur in the world, but it's somewhere between 3 and 6 million. And part of that reason has to do with how you define it, whether the lower gestational age is 20 weeks or 22 weeks or 24 weeks or 26. And everybody uses a different lower gestational age cutoff. What we do know is that the contribution of stillbirth to adverse pregnancy outcomes is large. It's underappreciated and until very recently understudied. But we know that almost all the stillbirths occur in low and middle income countries. So looking at the same kind of map that we were before, the lighter the color, the less stillbirths. And you can see that the worse outcomes, again, are sub-Saharan Africa. And in, sort of India, but not so much India anymore, but Pakistan and Afghanistan. You guys can figure where those are. So the countries with the best rates, again, are Norway, Denmark, Japan. Same countries always do well. The worst country in the world turns out to be Pakistan. And I'm going to talk about Pakistan because that's a country that I spend a fair amount of time in now. So the U.S. rate is not bad compared to the low-income countries, but it's still about twice what it is in Norway and Sweden. But again, Pakistan is worse than every place else. It's harder to know why a baby dies in utero. It's not like you got it in a nursery and you can watch it. Usually the baby just ends up dead. And so we in the global network have an algorithm that tries to get us to cause, but it looks like about half of the babies that die, the stillbirths that die, babies that are born dead, are due to some sort of asphyxial problem. Infection, how much, we've published papers that we thought that number was about 50% of the stillbirths were infection. I'm not sure that's true anymore. But I'll show you some of the studies we're trying to do to tease that out. But asphyxia, for various reasons, is the major cause of stillbirth. So Sweden, again, has had some very good data on stillbirth. And in this case, they look at mortality that's probably 28 weeks and more. So in the United States, we use 20 weeks as a cutoff. For Sweden, they were using 28 weeks. And so the orange line looks at Sweden. You can see some of the other countries that I didn't try to figure out who they were. But again, starting in the late 1930s, the stillbirth rate started dropping as well, pretty much in all developed countries. And in the U.S., the stillbirth rate has fallen from something about 40 to 50 per thousand births, so that's 4 or 5% of the babies were born dead, to less than 5 per thousand over about the last 7 decades. And just for the obstetricians in the room, the reduction in stillbirths in the last 70 years is one of the major success stories of modern obstetrics, and I think is one of the least appreciated. Medical care has really done something about reducing the stillbirth rate. And why did the stillbirth rate decline? It had something to do with monitoring fetuses prenatally, looking for things like fetal growth retardation, various kinds of heart rate abnormalities, the same kinds of things during labor, better care for women with preeclampsia, prevention and treatment of perinatal infections such as syphilis. So I went back and looked in 1920 in Baltimore, something like 20% of all stillbirths were due to syphilis. And obviously we don't see that almost ever. But in some African countries, that number is about right. Syphilis, where it's common, is a major cause of stillbirth. A lot of babies used to die from Rh disease, which is the mother makes antibodies against the blood components of the fetus. I was at Columbia as a resident, 68 or something like that. That's where Rogan, which is the treatment for that, was discovered. And I had a whole ward full of women with stillbirths. And for one reason or another, we didn't induce them. We waited for them to go into labor. But I had a whole ward full of women that I used to take care of with dead babies from Rh disease. And anyway, now we almost never see that. We provide better care for women with diabetes. We babies that stay in the uterus a little too long are more likely to die. And with better dating and with ultrasound, we know who those women are. And in most places, nobody is allowed to go more than about 40 weeks because of the increased risk of death. Now, coming internationally, the global network has shown that in low middle income countries that I've talked about, 70% of the stillbirths occur at or near term, are free of congenital anomalies, and occur during or just before labor. And this type of stillbirth is 50 times more common in low and middle income countries than in high income countries. And what that says is that medical care around the time of delivery, with appropriate monitoring and C-section when appropriate and all of that, really reduces those stillbirths which are asphyxiated babies. And with better obstetric care at delivery, intrapartum stillbirths in low and middle income countries should be substantially reduced or eliminated. We know that in the US, if there's a stillbirth that occurs during labor, that's a catastrophe. And that's a mark of poor obstetric care. And we just hardly see that anymore. But that occurs all the time in low-income countries. And this is from some data that we collected, it's back 6 or 8 years ago. But it looks at the regional variation of intrapartum stillbirths. So these are, the stillbirths that occurred during labor. And if you look at where it says developed regions, almost all the stillbirths occur before labor, and the rate is very low. If you go to Africa or South Asia, stillbirth rate is very high, but more than half the stillbirths occur during labor. And those should all be able to be reduced or eliminated with appropriate care. So this is another, for me, really important point, that if you want to reduce stillbirth in low-income countries, it's hard. And that's because the treatment to reduce those is delivery of the baby. There's almost nothing that we can do that prevents the asphyxia, essentially. And so if you discover fetal distress, the treatment is delivery, usually by C-section. If you have preeclampsia or eclampsia, the treatment is C-section, usually maybe induction. If you have obstructed labor, C-section. If you have a placental abruption, if you have a cord accident, almost all the treatments are C-section. There are a few things you can do. You can treat syphilis, you can treat malaria, but without the ability to perform a C-section, a trained birth attendant is not likely to prevent many stillbirths. And we, especially Margot, has been looking at C-sections in various places in the world. And I don't know if I put in the slide or not, but basically in sub-Saharan Africa, the C-section rate is 1 or 2%. And some studies that we and a number of other people have done suggest that you need a C-section rate of about 10 or 15% if you want to reduce stillbirths and maternal deaths. So the fact that there are virtually no C-sections done in sub-Saharan Africa say that they don't have the ability to reduce stillbirths very much. So we know that there are countries in Africa, most of them, in fact, that have C-section rates of less than 5% or 1 or 2%. But if you start breaking down the countries and look at rural areas or in a city, there's no C-section availability at all. And so that's a huge issue. So as part of a modeling exercise that we did, again, a number of years ago for a series in Lancet, we tried to understand the different interventions that might reduce stillbirths and the number of stillbirths prevented. And you can see you can reduce a little bit by taking care of diabetes. You can reduce some congenital anomalies with folic acid supplementation. You could reduce some by malaria prevention and treatment, post-dates, detection of treatment of preeclampsia, and so forth. The biggest thing one could do is give appropriate care in labor and delivery. And all of the others almost are sort of single subject interventions, and they have some impact. But the biggest impact is if you could provide comprehensive obstetric care. That's the way that you could have the biggest impact on stillbirth. Okay, switching to where do newborn babies die? Same kind of world map, different colors, but darkness shows very high rates of neonatal mortality, and sub-Saharan Africa and South Asia, or West Asia, are the areas where there's the highest neonatal mortality rate. The addition just says 99% of newborn deaths occur in low and middle income countries. It's not good when a baby dies in the U.S., but it doesn't happen very often. And most of those deaths are in Africa and Southeast Asia. So if you look at neonatal deaths by country, and these data come off of a CIA website that for some reason they collect. What the CIA does is beyond me, but for some reason on their website they have neonatal and mortality. But anyway, the best countries in the world, neonatal mortality is 2 or 3 per 1,000 live births. In this particular year, the worst neonatal mortality was in Angola, 20-fold more common. The U.S. again is more than Sweden, but not terrible. And then you can look at the countries in the global network. Very often Pakistan beats out Angola as the worst country in the world. This is the standard chart of neonatal mortality. About a third asphyxia, a third infection, and a third prematurity, with some other things thrown in. But and what we were talked about earlier is this prematurity stuff. It's not enough to know that the baby was premature when it died. Unless you know the reason it died, you can't put together a program to fix it. And a lot of the work that I'm doing now deals with trying to understand, for both stillbirths and neonatal deaths, what's the actual cause of that? And we're working mostly from a medical point of view. There's clearly all kinds of social issues as well. But what I'm going to just show you is sort of the medical causes. And that we did this from the literature back away, trying to understand what the likely distribution of the causes of death among in this case, preterm babies. And about half of the preterm babies that die worldwide die from respiratory distress syndrome. Where the Gates Foundation, because they're interested in putting together programs to try to reduce, especially preterm deaths, has asked us to really try to, not to go to the literature to find out what these numbers are, but to try to really understand which babies are dying and what is the context of those babies. And if I have time at the end, I'll talk about a study that we're doing to try to figure that out. But most of these numbers come from a clinician that said, you asked the clinician, why'd the baby die? Oh, it had breathing difficulty, so it's checked off as RDS. And I was talking earlier, one of those particular cases that was checked off as RDS, when we went back and we really looked at the bacteria in the baby, it was full of acidomycobacter all over the place. And it just didn't register to anybody that was the cause. So if you try to treat that as just RDS, you're not going to fix that particular case. This is another sort of historical look, and this is by Dr. Bina Kamath-Rain, who we talked about earlier, who's spectacular, now works with the American Academy of Pediatrics, and really has tried to do a lot of good stuff related to why do babies die, a lot of it internationally. And so what she went back and looked at was historically, between 1950 and 2000, the survival of babies with RDS and what were the treatments available. And so she looked at no treatment. Almost all babies with respiratory distress syndrome died. You remember back into one of Jack Kennedy's babies was 34 weeks. I don't remember the year, in the 60s. And with all the best treatment in the world, they couldn't save a 34-week baby with RDS. But oxygen played a big role. Oxygen and CPAP played a really big role. And then the addition of surfactant and advanced care made some difference. But the big things were CPAP and oxygen that led to the improvement in mortality. And in the US, the use of antenatal corticosteroids, I think I have some slides on that, increased gradually to about 1995 and rapidly thereafter. But what's important to understand is that most of the improvement in RDS survival occurred prior to the widespread use of antenatal corticosteroids and related to better, again, oxygen and CPAP, not so much due to antenatal corticosteroids. So corticosteroids, I'll talk about what are important, but the key was not that. The key was better care. Oh, okay. So I put in some slides about corticosteroids. Many of you know that in the 60s and 70s, a number of people looked at animal studies and they demonstrated that decreased neonatal mortality with corticosteroids occurred with sort of a chance finding in prematurely delivered sheep, actually. And so Liggins and Howie in the 70s, early 70s, did a randomized controlled trial. They found a huge decrease in RDS and an 80% decrease in neonatal mortality. And since 1972, the last I counted was 21 different studies, almost all in high-income countries, to examine the effect of antenatal corticosteroids. And they all had about the same result. This was the guy, Liggins, that discovered this, that did the first trial. And just for those researchers that have trouble getting things published, not that this ensured its routine clinical use. The study was rejected for publication by the Lancet on the grounds that it lacked clinical general interest. So every time I get a paper rejected, I go back to this slide. And so corticosteroids were not used very much, even though, through the 1990s, even though there was good evidence of benefit. There were 21 randomized controlled trials, and it just wasn't taken up in the U.S. And we tried to go back and understand what was going on in the U.S. That led to the lack of use. And the first thing is that it was inexpensive. It didn't make a profit for any drug company. So there was no drug company that was, had representatives out there and hawking it and whatever. The gestation, then there were a lot of questions. Gestational ages of effectiveness was not clear. For all of us that practice obstetrics, knowing when delivery would occur to target within the 24 hours and 7 days was often problematic. And then there were papers that this wasn't effective in African Americans. It harmed women with hypertension. There was concern about infections. There were long-term outcomes pending. And another thing that was happening about the same time is diethylstilbestrol, which turned out to cause cervical vaginal cancers, which is a steroid drug. It's causing harm, killing women. And so a lot of the obstetricians said, how can we give another steroid hormone without really knowing? And so I don't know which of these things were so important, but they all played a role. But in any case, in 1993, the NIH had a consensus conference to make recommendations. They did, and this just looks at the uptake after the consensus conference in 93. It was published in 94. And now most studies show that about 80% of preterm babies get appropriately treated. In the global network, one of the things that we have come to is that things that work in high-income countries may not be appropriate for low-income countries. And for that reason, among others, the global network did a study on corticosteroids in low-income countries to try to understand what would happen. And we did that in part to learn how to scale it up, but we also understood that there was no efficacy data from low-income countries. Nevertheless, without evidence of efficacy in low and middle-income countries, WHO, the Gates Foundation, USAID, all plan to support major rollouts of antenatal corticosteroids in a number of low-income countries. And some of us skeptics didn't think that was a good idea. So we did this large multi-country RCT, and number one, steroids did not reduce neonatal mortality in the targeted preterm infants, but increased neonatal mortality in stillbirth in the babies that didn't deliver in the preterm period. We suspected, but we don't know for sure, that infection, perhaps linked to the corticosteroids, appears to explain these findings. But in any case, plans to increase corticosteroids use in low and middle income countries are all on hold while additional studies are trying to understand what exactly happened in that global network study. Just a couple of slides on world population, which is a huge problem. You can see through about 75, the population was increasing in both developed countries, but in most developed countries now the population is leveled off, and what you have is huge increases in population in many developing countries. And for me, this is a huge problem. There's more pollution, there's less fresh water, there's less affordable energy, there's less healthcare resources for women, there's less food per person, and because 1/3 of the world's women are already malnourished, far worse pregnancy outcomes. So this is an issue that I personally haven't studied much, but is a concern to me. In developed countries, the births per women are usually under 2. In developing countries, that number might be 3 and 7. And it's coming down in many countries, but it's still high. And if you look at the same kind of world map, and you look at the population growth, in the green, there's no population growth. There's very low growth in the blue countries, and in the population growth rate % per year in sub-Saharan Africa and Pakistan, Afghanistan is more than 2% a year. So those countries still have very high growth rates. And you've probably all seen charts like this, but in the United Kingdom, if you look at 5-year age categories, it really doesn't change. The same number of people are born that die. And so that the population stays more or less the same. If you look at Zambia, where I used to work, most of the population is under 15. Half of them are girls. All of them are going to have 3, 4, 5 babies. And so the population is just going to soar. Since you're not going to stop the women from having at least 2 babies, even if you got it down to 2 babies per, there's going to be a huge population growth in that country. And contraception is a huge issue. Providing appropriate contraception is important. So just coming back to what I think is the main theme, if you look at the deaths that occur around birth, about 3/4 of the maternal deaths, I just figured out where the pointer is. So, about 3/4 of the maternal deaths, about half the stillbirths, and about 1/4 of the neonatal deaths are related to something bad that happens during delivery. So these are the intrapartum deaths. This is some data that we tried to put together, again, for a Lancet series a number of years ago. But it looked at the different interventions that would have an impact on maternal deaths, on stillbirths, and neonatal deaths. And by far, without any question, high-quality, facility-based obstetric and neonatal care makes the difference. The other stuff is tinkering around. Could be important, but it's essentially tinkering around the edges. What we have to learn how to do is to provide high-quality care around the time of delivery. We have studied who the people that do deliveries are. And this study was taken care of by Ana Garces from the site in Guatemala that works with the University of Colorado. And we surveyed a lot of people, but something now less than about half of the births of the 140 million births that occur at home and are attended by a traditional birth attendant. And what Anna found is that less than half of the TVAs can read numbers, tell time, or use a calendar. Few have had more than a month of professional training. Most cannot measure blood pressure or estimate when the baby is due. And almost none had experience with bearing any kinds of lacerations. So these are the women that are delivering half the babies that are born in the world. We've looked at skilled birth attendants, and that phrase is used, but who knows what it means. Skilled birth attendant can include physicians with the ability to manage complicated obstetric problems and do a C-section. But they also include midwives or nurses or community health workers with little training or experience in managing complicated deliveries. And this is a story I told earlier, but in Indonesia, the government, to reduce maternal mortality, trained something like 400,000 midwives to do deliveries. And maternal mortality didn't change at all. And it didn't change because the skill level that they taught was not related to why the women were dying. To save a woman's life from eclampsia or hemorrhage, you need a fair amount of skill, and that wasn't part of the training. The hospitals in many of the places where we work are terrible. I may have a slide that sort of documents it, but the skills of the people that work there, the equipment that's there, the attention to sterility, everything that we think a good hospital should do, shouldn't, just isn't there. Nevertheless, in many countries, there's a huge movement of women into hospitals to have babies. So where we work in India, 10 years ago, 30 or 40% of the women delivered in hospitals. Now it's 99%. And we see that trend all over in all the countries that we work. The issue is that in many cases, that movement hasn't resulted in a reduction in mortality. And we've just written a paper. In some countries it has, and in some countries it hasn't. And we're trying to understand what it is about the countries where the reduction where the increase in hospital delivery has actually resulted in a reduction in some kind of mortality. But when we look at hospitals, and we've done a number of studies of, the staff is poorly trained, there are delays in treatments, there are lack of medications, there's lack of equipment, and failure to use effective treatments, even if available. So it's this lack of attention to sort of what we call evidence-based medicine, even if they have the drugs or the antibiotic or the equipment, they're not used routinely. I'm going to come to Pakistan just for a couple of more minutes. So Pakistan is the country where I'm mostly working now. And when we look at mortality, this looks at maternal mortality over years. The group of countries down below, which between 150 and 100 per 100,000, include Kenya, Zambia, a couple of sites in India, Guatemala, and Pakistan stands out as having a maternal mortality rate 3 times the other countries. I thought I had another slide. Whether you look at neonatal mortality, whether you look at stillbirth, it's all the same. And so we have tried to understand, what is it about Pakistan that might explain this? And the first thing is that 80% of the women that we care for are illiterate. They've never been to school, can't read or write, compared to something like 20 or 30% across all our other sites. So this lack of education is important. Pakistan food instability is common. Almost all women in Pakistan are anemic if you use a hemoglobin of 11. But what we found in a couple of studies is that 8% of the women in Pakistan had a hemoglobin of less than 7. That woman in the States would be admitted and transfused, whatever. That's 8% of the pregnant women. Prenatal care is poor. Home deliveries with TVAs are common. And the quality of the institutional service deliveries, as I said, are terrible. So if Pakistan wants to reduce, in this case, its maternal mortality, it really needs to gear up in many areas. It's not any one magic bullet that's going to fix that. The other just comment to make is that many of the programs that we look at to try to improve outcomes, pregnancy outcomes, are focused on maternal mortality or neonatal mortality. It's not very common that you see a program that's trying to improve pregnancy outcomes. And so there's this tendency to silo the interventions. But what's clear is that the things that kill mothers, kill fetuses, kill newborns, and that what you really need is a program to try to improve outcomes across the board. Because the conditions that kill the majority of mothers, fetuses, and newborns are hemorrhage, eclampsia, intrauterine infection, obstructive labor, and they impact mothers, fetuses, and newborns. Okay, so in the last minute or so, the most obvious barriers to improving pregnancy outcome in low-income countries are lack of organized systems of care and the current low level of expenditure on health. And the quote that I have is, in the poorest countries, less than $25 per person per year. But when I used to work in Zambia, say 8 or 10 years ago, the health officer who was responsible for it in a number of clinics, 40,000 deliveries, had a budget of $180,000. $4 per woman for pregnancy. And he couldn't do much with that budget. So worldwide, more than 7 million fetuses and newborns, 300,000 of their mothers die before or just after birth. We know what interventions work to improve perinatal outcomes. None of this is really rocket science. We just don't know how to make these interventions available and sustain their use in low-income country settings. And the major challenge is creating a system of care in a place where there are few resources. I was talking earlier today with electricity in Pakistan, and the number of the hospitals we looked at, they had electricity maybe 12 hours a day. And how can you run a ventilator or a CPAP machine or sterilize stuff with very little electricity? Poor transportation, few trained health professionals, and where most of the birth attendants are illiterate and can't read numbers. And it's better than this now than it was. It's not quite half the births in the world, but it's between a quarter and a half. That's for baby when they're having. So, thank you. I only went over by 2 minutes. So thanks for sticking around. I'm around for questions. Am I, Margaret?
Yeah, I think if you guys have a minute to stick around, then we have time to answer. How receptive are they to? Okay, so I've always been interested in international health. Before I even started running my own projects, I used to do consulting, like trying to understand neonatal mortality in Egypt or in Colombia. So I had a fair amount of experience, but then started to do research, trying mostly in Zambia, mostly trying to reduce mortality from HIV, and built a large HMO dealing with that outcome. And then I just decided this is really important stuff, and just continued to work on it. And one thing leads to another. When you have a little bit of expertise or a few publications, somebody finds you to do something else. And my really good luck was right in the beginning, working with the Gates Foundation, just the day it opened, trying to understand neonatal mortality. And they've come back to me to work in many different projects over now 20 years. So I attribute that mostly to luck, being sort of in the right place at the right time. But the current study that I'm mostly involved in is they've asked us to try to understand why preterm babies die, why stillbirths die, so that they can use that data to build appropriate programs. And so they found not only me, but a group of us, can we answer that question? And they wanted it answered in South Asia. They had money. I said this earlier, anybody who has money, I'm certainly willing to talk to. And so that's sort of basically how we got into it. Okay.
Hello, Dr. Goldenberg. Thank you for your talk. And GN Network has been here over 19 years and has been a rich database. So I learned when I was a student at UAB in 2003, you provide PERC data for me for my dissertation. So the OBAR system, maybe since 1990s at Birmingham, obstetric automatic records data system. You apply that idea in a global context. So what's the lesson you learned building those important data systems to track?
One needs good data. I mean, that's, if there's one lesson to learn, if you're going to try to improve something, you need to know what the outcome is. And we've tried to get good data in a lot of different ways. The first thing that she was talking about was a computerized obstetric record system for the city of Birmingham, Alabama, that we built in 78 or 80. And once we had that computerized record system, we were able to, how many black women or how many white women or how much preeclampsia or how much of this. And we had no problem getting grants in those years because we had data. And the reason that the Gates Foundation comes to find us is because the global network has data. And not me, but the group at RTI is excellent in managing data. So Gates Foundation looks for people with data. And that's really the answer. All right, thank you, everyone. Oh, okay, go. One, two. Well, the major thing I said is that we don't understand why. And again, good data would help us to try to understand why the mortality went up, if in fact it did go up. And again, I'm not sure because our ability to capture maternal deaths in the United States is not very good. So for me, it comes back to data to understand what you're doing, what you're trying to fix, and how common that is. And it certainly has implications for low-income countries that if you're going to try to do something in those countries, you need to know what the outcome is trying to fix. And it keeps coming back to that. There's probably many other lessons, but that's what comes to mind at the moment. Okay, and last question. Uh-huh. The answer, on the slides, which I'm very pleased to, for each of the outcomes, the stuff that one has to do is pretty clear. What you need to work on, I believe, is if it's a hospital or a city or what, you need to work on building a system of care that you can do the appropriate things. And so it's not individual interventions, I don't think, that are so important. What's important is to have a system by which you can address issues. You can see if what you're doing is working, some sort of quality assurance, which I didn't even really hardly talk about. But if you want to improve outcomes, I think you need to look at what that outcome is. You need to look at what you're doing, and then to look and see if you do something different, does it change? And I talk about this in obstetrics, but most of what we do in obstetrics, there's no rationale, and there's little attempt to understand if it's made a difference or not. And so it's a huge problem in the U.S., but we have enough resources here that we can sort of overcome that. When you're in a place where there's virtually no resources, if you spend some of that resource on something that doesn't work, the opportunity costs are huge. So that's, for me, is to try to understand the system you're working in and to try to figure out what outcomes you're trying to address, and then trying to figure out what are the things. So, it takes a while when you go to a place to understand what's going on. What are the bad outcomes? What are people doing to try to fix it? And then, so it's complicated, and that's why I'm sort of not giving you a list. Because it's complicated. There's used to be a movie by It's Complicated, but it's complicated. Okay, thanks.